Modern clinical psychology structures the therapeutic alliance as a collaborative vehicle for change. We enter these spaces operating on a baseline assumption. The room is safe, the clinician is objective, and the goal is healing. But sometimes that alliance suffers a catastrophic breakdown, an event relational therapy scholars call a therapeutic rupture. The standard literature often writes these events off as normal relational friction, a bump in the road to be worked through. A true rupture does not look like friction. It looks like a structural collapse. When a breakdown is driven by a provider prioritizing institutional self-preservation over patient care, the resulting damage is a profound moral injury. Researchers originally developed the concept of moral injury to describe military veterans suffering psychological distress after actions that transgressed their deeply held ethical beliefs. Advocates are now applying this same framework to the psychiatric system to identify the specific harm caused by clinical betrayals. Labeling an ethical violation as a simple clinical disagreement strips the context from the harm. It prevents any genuine repair and quietly shifts the blame onto the patient. From the moment an intake form is signed, a distinct power asymmetry governs the room. The patient must invest a high degree of fiduciary trust in the clinician, relying on them to safeguard their psychological well-being. Because of this imbalance, the clinician functions as a de facto moral authority. This network diagram maps out that unequal dynamic. The fiduciary trust flows entirely uphill, from the vulnerable patient node toward the much larger clinician node. The rupture occurs when the clinician prioritizes internal stability over the connection, snapping the bond to defend themselves. The primary driver behind this defensive maneuver is institutional convenience. The clinician utilizes their authority to manage liability rather than treat the individual. A secondary driver occurs on an interpersonal level, where a therapist prioritizes their own emotional comfort during a crisis, pulling away when the patient requires engagement. In both scenarios, the provider's needs entirely override the patient's autonomy. Leveraging structural authority to secure administrative or emotional ease corrupts the clinical space, transforming it into a site of ethical danger. The clinical behaviors that cause moral injury generally fall into two distinct modes of structural failure: commission and omission. This flowchart tracks how failures branch out, splitting actions into commission or omission pathways. Looking closely at commission, we see a clinical decision bypassing clinical necessity entirely. Instead, risk assessment routes directly into a liability shield. In practice, acts of commission look like overt interventions. A clinician might deploy coercive safety protocols or force hospitalization on a patient. These heavy-handed tools are frequently wielded to mitigate personal risk and protect the provider's license, leaving the patient to bear the trauma of coercion. Moving to the omission path, the diagram shows a different kind of failure. Here, an incoming distress signal hits the clinician node, but the authority intentionally outputs a null response. This act of omission frequently manifests through what is known as the neutrality trap. Clinical neutrality is prized as professional objectivity, but when a patient discloses systemic harm or prior abuse by other practitioners, a therapist's refusal to provide ethical validation operates as a tacit endorsement of the original harm. Using clinical silence to avoid professional accountability abandons the patient entirely, locking them in a state of devastating moral isolation. When an individual reports one of these ruptures, the reaction of the larger psychiatric system follows a predictive defensive pattern. Institutional betrayal occurs when a system actively protects its professional hierarchy at the direct expense of patient safety. This flow model shows how a system processes a legitimate grievance. A data packet representing moral outrage enters the institution's black box filter. Inside, the system applies its primary defense, diagnostic overshadowing. The system aggressively strips the grievance of its original context. The patient's legitimate distress is reframed. The institution determines that the outrage is merely a manifestation of the patient's existing psychological diagnosis. Through this lens, justified anger at a moral transgression is coded by the institution as psychoanalytic transference or treatment resistance. The data then exits the system, but it has been entirely relabeled as pathology, generating a protective barrier that shields the original practitioner from fault. By transmuting a valid ethical complaint into a symptom of madness, the institution successfully gaslights the survivor and closes ranks. This systemic gaslighting produces a secondary, often permanent injury. It erodes the patient's epistemic agency, the basic human right to be believed about your own lived experience. The individual is thrust into a psychological double bind. To receive continued care, they must accept the institution's false narrative that they are internally unstable. On the other side, if they refuse that false narrative and maintain their own reality, they face complete, durable alienation from the entire helping system. This trap results in visceral disgust, profound spiritual withdrawal, and existential shame. Displacing a person's lived truth with a clinical story that blames them for their own injury actively reproduces the exact trauma the institution claims to treat. Standard symptom management and traditional therapeutic tools cannot repair structural ethical ruptures. Recovery requires abandoning the traditional medical model in favor of a restorative justice framework. True restoration demands explicit apportionment of responsibility. The institution must clearly acknowledge where it failed to uphold the moral contract. This table contrasts the two approaches. The medical model relies on mechanistic protocols and obfuscated accountability, while restorative justice demands relational ethics and structural accountability. Implementing this requires clinical supervision that actively interrogates power dynamics, rather than just training providers on how to mitigate risk. Systems must explicitly identify and dismantle the standard practices that incentivize defensive care over patient well-being. Explicitly naming these failures is the only way to dislodge the patient's belief that they are unhelpable. Resolving clinical moral injury ultimately requires one final intervention: the introduction of a moral witness. To be effective, this witness must exist entirely outside the hierarchy of the original transgression. They must be an untainted third party. This diagram shows how the moral witness intervenes. The independent witness node connects cleanly to the isolated patient, completely bypassing the broken institutional hierarchy to validate the patient's reality. This independent connection stabilizes the system. The witness provides a therapeutic adjacent space that is actually safe, allowing the patient to finally recalibrate their own moral compass. Within this space, moral indignation is redefined. It is an objective marker of psychological health. Final recovery does not require the patient to forgive the institution or reconcile with the clinician who harmed them. True healing occurs when the individual reoccupies their moral agency with integrity. They step out of the clinical narrative and refuse, at last, to treat their own outrage as evidence of disorder.